Okay. Hi. Good morning, everyone. I'll be starting off the topic. So, last time I was here, I spoke about another similar trial, that is the classic trial. So, at the end of the talk, I had told that there's one more trial that is coming up, which had already finished by then, and was expected to uh, have the publication sometime. So that was the lowest trial. So yeah, so Clovers is basically a crystallized liberal versus vasopressor early resuscitation in sepsis. So this is that's the name of the team of the investigators as well. Uh, so what they're looking at is whether to do more crystallized first or uh, to do to start off vasopressors early. So all the trials till now had uh, not answered this particular question. I'll come to that in some time. This is done by the National Heart, Lung and Blood Institute. So this is basically based in USA, uh, and it is their particular team is sorry, it's a separate chapter called Prevention and Early Treatment of Acute Lung Injury. This has been published in NEJM on February 9th of this year. Um, so before we go into this particular trial, so just a brief recall of all the evidences on IV fluids till date. This includes the first and foremost is the reverse et al. Publication on goal-directed therapy. This has been spoken uh, a lot about. Uh, and then we had the process, promise, and arise. These three landmark trials in IV fluids, where they went down on the IV fluid, uh, IV fluid of the IV fluid that the patients received progressively. So, uh, reverse et al. That started with 168 ml per kg during the entire stay. So that has come down to around 90 to 100 over the next few trials. Then after this, we had multiple small trials with patient population of less than 100. But the next uh, biggest trail was the classic trail that came up in 2022, um, which I've already discussed. Where I think it is the same point that you proved that going down on the fluids further is not harmful. But however, as I had already discussed, uh, the classic trail, the evidence was not so strong. Uh, the They were not actually able to come down on the fluid requirements drastically. So this was what we had discussed earlier. But however, what did happen is that uh, we could consider this as an evidence for going down on IV fluids further, because we already have some data which shows that uh, higher IV fluids is dangerous. So in the background of that, we had interpreted it accordingly. Mm, yeah. So anybody has anything to ask about the background of this study till now? This particular Clover trial, though, was designed somewhere in 2018. Their final manuscript that has come out now, they have quoted the Surviving Sepsis Guideline 2021. They have noted an issue here that a Surviving Sepsis Guideline only talks about the fluid bolus more, and maintenance is not a fixed volume. How much more, how much less is not told. Basically, they tell you to use dynamic indicators of fluid responsiveness. Yeah. So in the background of all these studies and guidelines, so they have set up a newer protocol where basically what they have tried to achieve is classical could not differentiate the IV fluids uh, between the two groups much. The difference was not very significant, and there were a few uh, back a few disadvantages over there. So their strategy was, sorry, their hypothesis was that a restrictive fluid strategy used during the first 24 hours of resuscitation for sepsis-induced hypotension would lead to a lower mortality before discharge to home by day 90 than a liberal fluid strategy. The important point to note here is the study period is only for 24 hours and the follow-up is for up to day 90. Okay, now comes the design of the study. So it's a multi-center, but it's a single country. So unlike all the other trials, this is based only in USA. Yeah, I might not say that this is one of the few. Other few were based only in Australia, but this is based only in USA. Uh, Unblinded. There's obviously no way you can blind how much fluids a patient is requiring is being given. And then we have the uh, okay, and it is a superiority trial. That means they are trying to prove that one is superior to the other. That is restrictive fluid or the early vasopressor. Uh, Randomization is web-based. Certification according to trial site. Important point. Of course, patient consent, all that is deemed to be necessary, but ultimately, even the physician also had to say whether his patient can be a part of the study or not. I'll discuss this importance later in the time. So their target was to detect an absolute difference between the two groups of 4.5 percentage point in the incidence of death before discharge to home by day 90, assuming that death would occur in 15% of the patients in the liberal group and 10.5% in the restrictive fluid group. So these numbers they were taken from the previous studies, and based on this, the uh, study was powered to 90% and an alpha level of 0.05. So they arrived at the sample size of 2320. Now we have, and also the important part of this is, it is they had a pre-specified criteria to stop the trial for efficacy in either group or for futility. So what it means is that there is uh, they had a team which would meet every 1 quarter of the study. So basically, they were supposed to have three meets, one after 1/3, 2/3, and the completion. So uh, in each of this, they would study if proceeding with the study would uh, is there a possibility that they might end up with uh, either efficacy or futility, means whether if they proceed with the study, they'll be able to prove that one is superior to the other, or will they be able to prove that the other one is inferior. So ultimately, this is what happened at the end of the second quarter. They told that there is no, it's for futility purpose they had to stop. That means even if they proceeded, they would not be able to prove that one is superior to the other. So this is just to save the time and the resources. So inclusion criteria is pretty much standard: age more than 18 years, a suspected or confirmed infection. So this is a very interesting point. This trial was designed even before the surviving sepsis campaign came up. Surviving sepsis 2021 camp. Uh, Guidelines. So at this time, we still had the initial CLUSOFA criteria for sepsis, but however, they did not choose that. They just defined it as broadly defined by administration or planned administration of antibiotics. So if a patient is going to be or has been administered antibiotic, they assume it to be sepsis, which is in line with the latest mm, uh, surviving sepsis guidelines of 2021, where they have taken out all the scoring systems from diagnosing sepsis. So it is ultimately the clinicians, it is left to the clinicians' discretion whether or not to label it as sepsis. Point two is about defining sepsis. Then they have defined septic shock as SBP less than 100 or MAP less than 65 or receiving vasopressor after a minimum of at least 1 liter. Exclusion, there are many points. What I would like to stress over here is more than 4 hours elapsed since inclusion criteria, more than 24 hours since presentation to the hospital. So what they're taking is only the ED patients who are being freshly diagnosed to be septic shock. Then severe volume depletion other than sepsis. So even though you fit those criteria, but you feel that there's no sepsis, they get excluded. Uh, Pulmonary edema. Then these two are important. Treating physician unwilling to give additional fluids as directed by the liberal protocol, or unwilling to use vasopressors early as directed by the restrictive protocol. So this is a study where at each point it looks like to improve the compliance to the protocol, and yeah, basically to improve the compliance and to recruit more patients. The physicians have been given a lot of free will to decide whether to accept a case for the study or not to accept. So what happens? This is the study protocol. In the restrictive fluid group, so the first is the inclusion criteria. So in the restrictive fluid group, you start the restrictive fluid protocol. That is, you halt all the boluses and maintenance fluids. Basically, you shut down all the fluids. Then you administer fluid boluses up to 2 liters of total fluid, including pre-randomization, but again at the discretion of the clinical team without uh, criteria for rescue fluids being met. So what this means is, when you start the study, the patient should have received around 2 liters. Here, there is a caveat. They have allowed the physician to alter this as he wants, but he should have received a bolus. Then, is the patient in uh, hypotension? If yes, you start off the vasopressor. If it's already there, you adjust it, add a second vasopressor, and then reassess. So this is till the shock gets resolved. Then, uh, if there is no shock, you continue to limit the fluids to keeping the vein open. Does any nurse here want to tell me what is this keep vein open? Okay, so keep vein open is where you give a very minimal fluid. Usually it's 20 or 30 ml per hour. So just to avoid that IV cannula from getting blocked. So you just restrict the fluid to that, medications and nutrition. And then you keep reassessing every 1 hour. So in this study, all assessments happen at every 1 hour. When do you use rescue fluids? A lot of criteria. Important is all basically all these are severe. That is SPP of less than 70, MAP of less than 50, refractory hypertension, lactate of more than 4, not 2, and and increasing trend. Sinus heart rate of more than 130 for more than 50 minutes. Echocardiographic evidence. This is of interest that here the echocardiographic uh, they have defined it in the supplementary material. So what it says, one of the points is IVC less than 0.5 mm, sorry, 0.5 centimeters. So 1.2 mm being the normal, 0.5 is uh, a very small IVC basically. So that means to say that the threshold for giving IV fluids is very high. But there is one uh, point here again. Rescue fluids may be administered at any time if the clinical team believes it is in the best interest of the patient. So as I keep pointing out again and again, there is again and again the physician, the primary physician is given a lot of freedom to overrule these protocols. In the liberal fluid, the initial things are all the same. You start liberal fluid protocol, give halt all the maintenance fluids. You give a bolus of 2 liter, monitor for signs of overload. At end of 1 liter, you assess and see if you want to continue or not. Then, if the patient has again the same criteria, MAP less than 65, lactate more than 4, decreased output. So here the thresholds are a little lower, sinus heart rate of more than 110. So if these are there, if these signs of hypertension are there, they administer a 500 ml bolus and then reassess. So this keeps on going on till he's out of shock. So if he's not in shock, what they do is start tapering off the vasopressors and keep assessing. So when you start tapering vasopressors, if you find hypertension, you would go to this and end up giving more fluids over here. There we had in the other protocol, we had the concept of rescue fluids. So here they use rescue vasopressors. So in rescue vasopressor, if you have a severe hypotension, Um, Basically, those other criteria, lactate of more than 4, uh, already 5 liters of fluid has been administered, and yeah, when this happens, they use vasopressor. So here you see the indications for vasopressor is very minimal, and again the same period, if the physician feels he can give it. Okay, so now coming to the statistics. Uh, Baseline characteristics, nothing much. Age, gender, everything has been very well matched. There was no significance in any of these variations. So this is important. Median volume of IV fluid administered over 6 hours are jump, but over 24 hours, 1.2 liters. In the restrictive fluid group, liberal fluid group, 3.4 liters. This is during the trial intervention. Do not forget that before this, there's already 2 liters bolus given for all. Then you have vasopressor administration. In the restrictive fluids, 59% of the patients required vasopressors, whereas in liberal fluid, 37% required vasopressors. That is very much expected because of the protocol. Time to randomization, time from randomization to first vasopressor. Of course, in restrictive fluid group, it was very early at 1.8 hours, while in liberal fluid, it was around 3.2 hours. Duration of vasopressors, as expected, again, 9.6 hours in the restrictive fluid, while it was much lesser at 5.4 hours in the liberal fluid group. So what we see at this level is there's a good amount of differentiation in the IV fluids between the two groups. So if you remember the classic trial, at this level they had a differentiation of around 800 ml. So after noting this, we have the most important uh, point to be seen. This is what I've shown you till now is in the manuscript published as the part of the main article. But if you see into the table in the supplementary group, in the supplementary material, so what is the amount of fluid that the patients have received over the next 7 days? Day one, the restrictive fluid has received 604, while the liberal has received 565. So you see, on day one, the restrictive ended up getting more fluids. Day two, 782 at restrictive, 800 at liberal. So they are almost equaling. Overall, in the rest of the 7 days, both the groups end up getting similar amount of fluids. If you see, it's all just a few ml difference. So the next few days, this separation has not been achieved. Outcomes, uh, I've kept it small because basically none of this are statistically significant. Death 14.9, ardent free days 24, 23.6. So everything, ventilated related metrics, number of hospital admission and length of stay, need for renal replacement therapy as well, uh, is all the same. Terigo score, SOFA scoring, um, anything is, there's no variation. ARDS onset between day 1 and day 7 is also not significant. Liberal fluid getting just 1% more. So this is again what is shown in the main manuscript. Okay, so this study had a predefined subgroup analysis which has been done. So if you see this graph, you find that most of them are not significant. Either restrictive fluid or liberal fluid doesn't really matter much, except in two subgroups. To note over here, end-stage renal disease. So in end-stage renal disease, restrictive fluid strategy is better, which is very much obvious. One thing I'm not sure how to interpret this, location at the time of randomization, ED versus ICU or hospital ward. So a patient who has come to an ED, you can still follow restrictive fluid, but it seems to suggest that a patient already in the hospital, either in the ward or ICU, develops septic shock. You definitely have to go for liberal uh, fluid strategy. This seems to be better. This is again in the supplementary material, not in the main manuscript. I've taken only the things that I want to highlight over here. Most of them are not significant, except that I wanted to see these two values with a p-value of 0.02 and 0.09. Both of these are basically fluid overload and pulmonary edema. A fluid overload was more in the liberal fluid group with 0 in restrictive fluid group. This was statistically significant with a p-value of 0.02. I'm not sure what is the definition of fluid overload and pulmonary edema differently, but again, pulmonary edema 0 in the restrictive fluid group and 3 in liberal fluid group. This had a p-value of 0.09. These are the Dr. Lotus. These are the total numbers, I believe. Yeah, it does look like total number of patients.
So only one person got pulmonary edema in the liberal group and none got in the control group. Is that
One is non-serious and two is serious. So total
right?
three.
Three got.
Yes.
That's a total of 780 patients, isn't it?
Yes, yeah. But the p-value has come to be 0.09.
The numbers are so high, so p-value would actually mean that.
Yeah,
I don't think
yeah.
it's a lot. So the
Mm.
fragility level here is very, very less.
Yes, that I agree. Yeah,
So I wouldn't take this
yeah,
serious because it becomes very fragile, right? So the serious one is two. Even if you
yes,
have one person move from this end to the other end, the
yeah,
whole equation changes out.
yeah. That table doesn't mention what exactly is these numbers. Uh,
If it is the actual number, actual incidents, then
okay, let me just read this line.
it looks a
P-values,
bit odd. Yeah, go ahead.
p-values are calculated from weighted Poisson regression. Weight for serious adverse event is 2. Weight for non-serious adverse event is 1.
Sorry, what
W
was it? Rate.
weight WEIGHT. Weight for serious adverse event is 2. Weight
So
for
they've given
non-serious.
weightages for it. Not this is not the actual number of events.
Okay, so yeah, that part I'm not sure. So
I don't
this
know.
is from the supplementary material in the AnyGem website.
Right. Right.
Um, so that's so uh, the p-value has come to be significant. That part I'm not sure.
Again, p-value we need to take it with a pinch of salt, especially when you are actually seeing numbers.
Hmm.
Even though it is statistically significant,
Hmm.
it may not actually mean a lot.
Yeah.
Especially when you go with high numbers, right?
Yes.
Even a small difference would be significant.
Yeah. Exactly.
So we'll need to be a bit more cautious in this. Okay.
Yeah. And for the same reason, I did not take this one more thing where one more set of table where they say death is only one in non-serious, while it is four in one in restrictive and four in non in liberal. So I believe these numbers are something else. I could not find that. But yeah. So what at least what we can see is there's a small uh, increase in adverse events in the liberal fluid group. So the author's conclusion here is a restrictive fluid strategy did not result in significantly lower or higher mortality before discharge to home by day 90 than a liberal fluid strategy. So it did end up with a very similar uh, uh, outcome like the classic uh, trial. So now coming to the analysis of this particular study, uh, the pros are that there was a very good fluid separation in first 24 hours. This is something that many many of the studies have tried to struggle till now. The classic trial, or we have some other trials. We had s- uh, a study uh, which studied the effect of using higher map and lower mapping uh, septic shock using vasopressors. So here also, though they were trying to aim for uh, or the difference of a target of 65 and 75, uh, the actual what they ended up with is a very narrow margin. But however, this study was able to achieve a good fluid separation. This might be this. So what this has to be interpreted along with another good point is very high protocol compliance. 97 to 98% in both the groups. So this high protocol compliance was probably achievable because of the free hand given to the physician in the protocol. And they have used a broader definition of sepsis, as I already spoke. Though in 2021 the sepsis guidelines accepted that took out all the scoring systems from the definition uh, or identification of sepsis. This study being designed in around 2017 and 18, at that time itself they had accepted this broader definition of sepsis. Another important point, they used peripheral lines to administer vasopressors. They did not wait for a, a, a central line. And even in spite of this, there were no life-threatening adverse events, with around 2 or 3 patients having some cannula related adverse events because of the vasopressors. So the cons, it is a single country based study. So whatever, I think we have to be careful when we uh, generalized this study to the entire world. Another uh, s- a study of similar significance was when we adopted the Clusofa. Clusofa was initially this, it was based on the database of German ICUs. So uh, the initial 2017 sepsis guidelines adopted at Clusofa, and over time, or rather very quickly, we realized that this can't be accepted all over the world, and so the 2021 new guidelines had got away with Clusofa. Only 25% of those who were screened were enrolled. Uh, so why? Because of the exclusion criteria, and in that exclusion criteria, there was two important points, which basically means the physician can decide whether the patient uh, joins the study or not. This would be a huge selection bias. So basically, the physician also had the choice during the study whether they want to continue or drop out. If he feels that the patient requires extra fluids, he would end up giving it, or if he feels the patients need to go on more vasopressors, he would do that. So there was a lot of uh, free hand given to the physician. So this could be a potential for bias. Weight of patients is not analyzed. So what does this mean is, so a 2 liter bolus for a 50 kg man would be different from a 2 liter bolus for a 100 kg man. Uh, it's 20 ml per kg and 40 ml per kg. Uh, so this was not taken into consideration in this study. There's no mention of any weight anywhere. The IV fluids administered over the next 7 days was similar in both the group, which is what I've already shown you. So what this means is, could a 24-hour fluid restriction be expected to have a change in 90-day mortality? So when you ask this question, it becomes very clear that uh, obviously it's not possible by having to restrict a fluid uh, administration in the first 24 hours and having the same fluids over the rest of the hospital stay. You expect it to show a difference in the mortality or any parameter for that matter. So as you saw, the day two, the restrictive fluid group ended up getting more fluids. So take home points. Most important point, though there's a lot of discussion on restrictive versus liberal fluids, early vasopressors versus late vasopressors. One thing is unchallenged is bolus dose for septic shock is still a minimum of 10 to 30 ml per kg. There's no concept of restricting the fluid for a fluid bolus. Restrictive fluid strategy does appear to be safer. Why? Because there is already enough evidence for increased mortality with increased IV fluids. Though these are not very big studies, not named trials, but yeah, we do have evidence for this. Then there is increased morbidity of statistical significance in this study as well. But yeah, as we discussed, these numbers, um, how to interpret them, you're not really sure. But yeah, there is some increased morbidity over here. Then a non-significant increase in mortality in the liberal fluid group here as well. So though it might be that it is of not of statistical significance, but still the actual mortality is higher in the liberal fluid group. So last time when we spoke about the classic trial, we had told that we would have classic, we would have closed trial coming up. So now we have two more studies in the pipeline, Arise Fluids and Andromeda SOC 2. Both of these are very early in the study. Probably, I'm not sure, but at least they would probably be taking another 2 or 3 years to come up. Yeah, thank you everyone. Any doubts? Anybody wants to discuss anything?
Fluids in ICU and ARDS are two common topics,
Yeah,
which has been there in terms of the studies and evidence, and we've been studying it for the last 20 years, 30 years, and every time you have something, new evidence comes up and things change. So that's one. I have few things to just place as a comment. I don't think this is hugely different over this thing, right? Classic trial.
classic. Yeah, classic did not study the vasopressors. Yeah, here they studied vasopressors. That's the
Yeah,
main
but
thing.
still, I mean,
Yeah,
Classic actually started as, which is, actually, it was not a superiority trial, but
yeah, correct. Yeah,
they wanted to see which is, I mean, how it goes.
yeah, yeah.
Um, they started as a superiority trial, they couldn't complete and stuff. That's one.
Mm.
My concerns are, I think that's again mentioned, is they have not used dynamic indices for fluid
Yes,
distribution, right? That's
yeah,
one.
yes, yes.
And yes, 24-hour fluid administration may not change a lot in terms of 90-day mortality. Probably that was a bit of an overstretch, and they wanted to see a mortality reduction by 5%, which
Yeah,
I think is too hopeful.
yes,
Uh, but it was pragmatic in the sense that we left a lot to the physician to decide.
definitely,
And
definitely.
in spite of all of it, the separation between the liberal and the restrictive was huge.
Yes,
When you leave it to the physician, it usually would be that
yes.
and try
The
to
mud.
think about things.
Yes.
But somehow the separation maintained, and even with that separation of what 2 liters in both the groups, it
Yes,
would
yes,
show a huge difference.
yes.
I was interested to see the rates of renal replacement therapy or AKI in the restrictive group, but
Mm.
I feel it's not significantly different
Not. No,
compared to the liberal group, right?
it's exactly the same. I think.
Yeah. That was a surprise to me
Yeah.
because I had expected that to go up the previous one, right? Yeah,
Initiation of Faraki, 24, 24. Exactly the same.
yeah, and even the KDIGO scores didn't change,
Jinxings, yes.
so that was a surprise for me because
Mm.
you would have expected renal replacement therapy or AKI to happen, and
Happen in
even
the
the entry days didn't change. That
yes,
those are the only two things you look for in fluid resuscitation, anyways.
yes,
Um, and the forest plot, the next one. The first one was the ESRD was expected, isn't it?
yes,
Restricted
yes,
hypertension.
yes,
But the other
yes.
one, I think it's crossing the
Crossing
race,
the side as well. Yeah.
crossing the other side. So
Mm.
I don't think it makes a lot of
Yeah. Not a very strong one. Yeah.
not a very strong pointer.
Yeah.
So that's one. One other point I wanted to make is both the restricted and the liberal strategies did not use maintenance flow.
Yes.
Correct?
Yes. Both use boluses.
Both use boluses.
Yeah.
Why I bring this point is this is actually the standard of care.
Yeah.
People don't use maintenance anymore. So
Mm.
even in the liberal group where they wanted to give a lot of fluids, they didn't use maintenance fluid. They use boluses when needed.
Mm.
So as a practice with us, I think we should. That's the only take home I would do. Is
Mm.
by no means we should be using maintenance fluids.
Yes.
Not a lot of us do it, but just putting
Mm.
it out for perspective's sake. But will it change my practice? I don't,
Not much. Yeah.
I don't think so.
Mm.
Okay, cool.
Okay. Okay. Thank you. Is there anybody else or shall I wind up?